A Guide to Cardiac Vasoactive Drips, Part 2, Vasoconstrictors Used for Shock, the Catecholamines.
Welcome back to the Pharm Easy Tutor. My name is Ken Eto, and I'll be continuing my lectures on cardiac vasoactive drips. In Part 2 of this 4-part series, I'll be going over the pharmacology, dosage, and clinical use of catecholamine vasoconstrictors. I'll also discuss the side effects of catecholamines, including how to manage extravasation. An introduction to refractory shock will also be reviewed. Here's Part 2, the catecholamines.
Norepinephrine is considered the first-line vasopressor of choice for all types of shock. It predominantly activates alpha-adrenergic receptors on vascular smooth muscle cells, resulting in potent vasoconstriction. It also has modest beta-1 adrenergic effects that help to maintain cardiac output. Beta-1 effects can become more prevalent at higher doses, which can cause toxicity. The usual initial dose ranges from 10 to 15 micrograms per minute. I selected the magic number of 8 micrograms per minute as the cutoff dose, which separates very critical patients from patients that have a good chance to be weaned off of norepinephrine. This was derived from the VAST study, where less severe sepsis required 5 to 14 micrograms per minute of norepinephrine. And also, it was derived from the ATHOS-3 study, where a study drug was given if the norepinephrine dose reached 0.1 micrograms per kilogram per minute, which is equivalent to about 8 micrograms per minute. Administration generally results in a clinically significant increase in mean arterial pressure, with little change in heart rate or cardiac output. As the dose of norepinephrine increases, receptor desensitization and tachyphylaxis can occur on vascular smooth muscle cells. Tachyphylaxis is described as a rapidly diminishing response to successive doses of a drug, rendering it less effective. When norepinephrine was compared to epinephrine in a randomized controlled trial, there was no difference in time to achieve target MAP or in 28-day or 90-day mortality. However, patients who received epinephrine developed a significantly higher rate of adverse reactions, tachycardia, lactic acidosis, and hyperglycemia, compared to patients on norepinephrine. When norepinephrine was compared to dopamine in septic shock, norepinephrine was more effective at reversing hypotension, and also dopamine induced more arrhythmias than norepinephrine did and was associated with an increased 28-day rate of death among patients with cardiogenic shock. At the bottom of the slide, I provided a table that summarizes each drug. Epinephrine has dose-dependent effects. At low doses, it has predominantly beta-adrenergic effects. At high doses, alpha-adrenergic effects and vasoconstriction become more clinically significant. First, let's talk about low-dose epinephrine. Epinephrine is the drug of choice for anaphylaxis at low doses. At low to moderate doses of 2 to 10 micrograms per minute, epinephrine has a higher affinity for beta-2 receptors than alpha-1 receptors. In anaphylactic shock, epinephrine stimulates the beta-2 receptors in the pulmonary endothelium, resulting in bronchodilation that improves bronchospasm. An increase in the inotropic effect and a decrease in the systemic vascular resistance improves airway edema from the vasodilation of the capillary beds. Now let's move on and talk about the high-dose epinephrine used for shock. At high doses, greater than 8 to 10 micrograms per minute, epinephrine is a potent alpha-1 receptor agonist, causing vasoconstriction. When compared to norepinephrine in patients with septic shock, epinephrine is associated with similar mortality. But epinephrine causes a higher incidence of tachycardia, arrhythmias, lactic acidosis, and hyperglycemia. Therefore, epinephrine is considered a second-line agent or vasopressor for septic shock. In severe cases where patients are not responding to norepinephrine, epinephrine can be added to norepinephrine when an additional agent is needed to maintain adequate blood pressure. However, epinephrine's mechanism targets the same alpha-1 receptors as norepinephrine, which may already be saturated at high doses, rendering epinephrine less effective. Epinephrine is also associated with an increased risk of splanchnic vasoconstriction, with resultant decrease in splanchnic blood flow, leading to ischemic bowel. And again at the bottom, I created a table that summarizes what we just went over. Phenylephrine is a nearly pure alpha-1 agonist. Activation of alpha-1 receptors by phenylephrine will increase systemic vascular resistance and cause systemic vasoconstriction. However, due to a baroreceptor-mediated reflex bradycardia, it can decrease cardiac output. This impairs tissue blood flow and has a negative effect on circulation, especially for the hepatosplanchnic region. For this reason, phenylephrine is rarely indicated and is not recommended for the routine management of septic shock. There is limited evidence supporting its use in sepsis. However, phenylephrine can be considered in limited use in certain situations, as an adjunctive vasopressor in refractory hypotension, for short-term management of transient profound hypotension, and because it has a low proarrhythmic potential due to its lack of beta-1 adrenergic effects, you may consider using it if serious tachyarrhythmias occur with norepinephrine or epinephrine. As a side note, phenylephrine is structurally related to epinephrine, but it is missing a hydroxyl group on the typical aromatic catechol ring. Therefore, it is not technically considered a catecholamine. It is a synthetically derived drug. And here's a table at the bottom of the slide that reviews what we just said. Dopamine has dose-dependent effects on 3 receptors. At low doses, 2 to 5 micrograms per kilogram per minute, dopaminergic 1 receptors are activated. Dopaminergic effects may selectively dilate the hepatosplanchnic and renal circulations. At moderate doses, 5 to 15 micrograms per kilogram per minute, beta-1 adrenergic effects are seen. It predominantly acts on beta-1 receptors to cause enhanced chronotropy and inotropy. And at high doses, greater than 15 mics per kilo per minute, alpha-1 adrenergic effects and vasoconstriction occur. Dopamine's main effect is on alpha receptors, which cause vasoconstriction. When norepinephrine was compared to dopamine in septic or cardiogenic shock populations, dopamine induced more arrhythmias and was associated with an increased mortality. Twice as many arrhythmias occurred with dopamine than norepinephrine. This is probably caused by dopamine's strong beta-1 effects. Dopamine is not recommended as a vasopressor for shock because of its greater chronotropic effects and tachyarrhythmias compared to norepinephrine. Dopamine should only be used as an alternative agent for vasodilatory shock in highly select populations with relative bradycardia and or low risk of developing tachyarrhythmias. Let's talk a little bit about low-dose dopamine. Does it really work? At low doses, dopamine primarily acts on D1 type receptors and selectively dilates the hepatosplanchnic and renal circulations, increasing renal blood flow by as much as 30 to 40%. However, controlled trials have not shown a protective effect of low-dose dopamine on renal function compared to placebo, with no benefit regarding renal replacement rates, renal function, or mortality. There is strong evidence against the use of low-dose dopamine for renal protection, and its routine use for this purpose is no longer recommended. And again at the bottom, the table below reviews what we just covered. Here's a complete table that reviews all of the significant aspects of the 4 catecholamines that are used as vasoconstrictors for shock. Let's discuss some of the adverse effects of catecholamines. Dose-dependent arrhythmias such as sinus tachycardia, atrial fibrillation, and ventricular arrhythmias can occur. The proarrhythmic risk is highest with epinephrine, dopamine, and dobutamine, moderate with norepinephrine, and lowest with phenylephrine. Peripheral ischemia can occur. All catecholamines can produce excessive vasoconstriction in any target vascular bed, leading to complications such as coronary infarction, mesenteric and organ ischemia, or limb and digital ischemia, also known as purple toes. Metabolic effects can occur, such as epinephrine producing hyperglycemia and lactic acidosis by activation of beta-2 receptors. A significant adverse effect of catecholamines is extravasation. Extravasation is defined as the extravenous administration of a medication or solution that has the potential for severe tissue or cellular damage into the surrounding tissue. Now, ideally, catecholamines should be administered via a central line to minimize the risk of extravasation. However, when necessary, catecholamine vasopressors can be administered via a peripheral venous line, but there is a 2 to 5% risk of extravasation to occur. If a catecholamine vasopressor is to be administered peripherally, you should limit the duration of infusion to 24 hours, and the vasopressor dose should not exceed a maximum of 25 micrograms per minute of norepinephrine equivalents. How do we treat catecholamine extravasation? The drug of choice is phentolamine or Regitine. It's an alpha receptor blocker that's available as a 5 milligram powder vial. The powder is diluted with 10 mL of normal saline. Small amounts are injected subcutaneously with a 27-gauge needle into the affected area around the leading edge of the extravasation site. Recently, phentolamine has had several drug shortages, and so other agents need to be investigated for the use of extravasation. One of these agents is terbutaline. Terbutaline is a beta-2 receptor agonist that causes peripheral vasodilation. The 1 milligram per ml solution is diluted in 10 mL of normal saline. Small amounts are injected subcutaneously into the affected area. Another agent that can be used is nitroglycerin 2% ointment, which is a venodilator. 1-inch strip is applied to the site of ischemia. This may be redosed every 8 hours as needed. Other modes of therapy include applying warm compresses to the area and elevating the affected limb to minimize swelling. Please note that terbutaline and nitroglycerin ointment are off-label use for extravasation. Phentolamine is the only drug that is FDA approved for this indication. What do I do if the infusion rate of norepinephrine drip keeps increasing with no improvement in blood pressure? Here are 2 important points to remember. 2 important principles regarding acid-base status. First, acidemia diminishes the vascular responsiveness to catecholamines and will decrease the sensitivity of the myocardium to catecholamines. This will result in increased catecholamine requirements. Correcting the acidemia with sodium bicarbonate can result in improved cardiac contractility and vascular responsiveness to the catecholamines. Therefore, if your patient is acidotic with a pH of, say, 7.2, more than likely norepinephrine will not be effective. Consider administering sodium bicarbonate to increase the pH so your drips will work. The second important point is to never administer bicarbonate in the same line as the catecholamine drip. This is a physical-chemical drug-drug interaction where the high pH will chemically degrade the catecholamine and inactivate it. Refractory shock is defined as persistent hypotension requiring high doses of vasopressor agents to maintain an adequate blood pressure. Higher cumulative vasopressor dose requirements are consistently associated with organ dysfunction, poor outcomes, and higher mortality. Reducing the duration of hypotension is associated with decreased mortality in septic shock. In severe shock, a patient needs norepinephrine doses of greater than 0.2 micrograms per kilogram per minute, about 14 micrograms per minute in a 70 kilo patient, in order to maintain adequate MAP. In refractory shock, a patient needs norepinephrine doses of greater than 0.5 micrograms per kilogram per minute, about 35 micrograms per minute in a 70 kilo patient, for adequate MAP. This is associated with a high risk of death. Finally, norepinephrine doses of greater than or equal to 0.8 micrograms per kilo per minute, about 56 micrograms per minute in a 70 kilo patient, is associated with a 50 to 80% mortality rate. Refractory shock, using catecholamine-sparing agents. What is catecholamine-sparing combination vasopressor therapy? Adding a second catecholamine vasopressor may not be useful in refractory shock. This is because as the dose of norepinephrine increases, receptor saturation, desensitization, and tachyphylaxis can occur on vascular smooth muscle cells, rendering epinephrine and phenylephrine less effective. This will yield lower efficacy and greater adverse effects. Can you add a second vasopressor that has a different mechanism of action instead? When tachyphylaxis occurs, adding a second vasoconstrictor with a complementary mechanism of action that is distinct from catecholamines should be used to maintain blood pressure. What are these agents? Vasopressin and angiotensin II. There is a push for early use of these multimodal, catecholamine-sparing adjunct vasopressors, vasopressin and angiotensin II. Here's an example of a shock treatment algorithm published by the Surviving Sepsis Campaign. Let's review it. We begin with starting norepinephrine drip to control blood pressure. Norepinephrine is titrated up to a maximum dose between 35 and 90 micrograms per minute. If the MAP target of 65 millimeters of mercury is not achieved with norepinephrine, and overall clinical response is not achieved, then the catecholamine-sparing drug vasopressin is started at 0.03 units per minute. So this shock treatment algorithm recommends starting vasopressin ahead of another catecholamine for refractory shock. If the target MAP is still not achieved, then epinephrine can be added and increased to a maximum dose of 20 to 50 micrograms per minute. IV steroids should also be given at this stage. If the MAP target is still not achieved, then phenylephrine up to a dose of 200 to 300 micrograms per minute can be added, which is a very high dose. Note that the Surviving Sepsis Guidelines does not mention the use of phenylephrine. This algorithm states that the upper dose ranges of the catecholamine drips are not evidence-based, and so the maximum doses should be based on the individual patient's physiologic response as well as on side effects. The suggested doses are close to the maximum recommended doses. The algorithm also agrees that dopamine should be only used as a vasopressor in the presence of sinus bradycardia, and phenylephrine may be used if serious tachyarrhythmias occur with norepinephrine or epinephrine. Here are some take-home points for you to remember. Norepinephrine is an alpha-1 receptor agonist that is considered the first-line vasopressor of choice for all types of shock. A norepinephrine dose of 8 micrograms per minute is considered a cutoff dose, reflecting the severity of the patient's clinical status. Epinephrine was as effective as norepinephrine as a vasopressor, but it had a significantly higher rate of tachyarrhythmias, hyperglycemia, and lactic acidosis. Phenylephrine should only be used on a very limited basis due to its effect on decreasing cardiac output. And dopamine compared to norepinephrine induced more arrhythmias and had an increased mortality rate, so it is not recommended in shock. There's also strong evidence against the use of low-dose dopamine as a diuretic. Extravasation can occur with catecholamines if they're administered peripherally. The treatment of choice is phentolamine. Acidemia decreases the vascular responsiveness to catecholamines, so always check the patient's blood pH. Refractory shock occurs when persistent hypotension requiring high doses of norepinephrine, greater than 35 micrograms per minute, is needed to maintain an adequate mean arterial pressure. As the norepinephrine dose increases, receptor saturation and desensitization can occur on the vascular smooth muscle cells, rendering them ineffective to a second catecholamine. Instead, adding a second vasopressor with a different mechanism of action, such as vasopressin or angiotensin II, should be considered. In part 3 of this 4-part series on cardiac vasoactive drips, we will investigate the use of the catecholamine-sparing agents vasopressin and angiotensin II, take a look at some other rescue agents used in shock, and discuss the use of inotropic drips used in shock. So stay tuned. Thanks for tuning in to watch this installment of the PharmEasy Tutor. I hope you learned something that you could use at school or in practice. If you'd like to continue to see more of these types of tutorials on YouTube, please make sure to click on the subscribe button below to change it from red to gray. Also, if you like this video, I would appreciate it if you can click on the thumbs up icon below to change the color to blue. If you have any comments or questions, please feel free to add them in the comments section below, or share this site with someone else. Stay tuned to the PharmEasy Tutor channel for more lectures in the upcoming weeks. So until next time, remember to take it easy.